Welcome to Indians Forensic Psychiatry Session 5. Today we'll be dealing with capacity assessment according to Mental Health Care Act of 2017. Today we have with us Professor Suresh Paramat sir, who is Professor of Psychiatry at NIMHATS. Sir, over to you, sir.
Thank you. Good evening, friends. Today we'll be discussing about the mental capacity assessment. First, I would like to tell you that I'm Dr. Suresh. Many of you may know me. Apart from doing MD and DNB, I have done my PhD in law from National Law School, and also my thesis was on Mental Health Care Act. And currently, I'm head of community psychiatry, telemedicine, and consultant in forensic psychiatry. And currently in NIMHATS, Bangalore. These are my affiliations. And before I go ahead, I would like to have my one disclaimer. The cases discussed during this whatever presentation, they are all purely imaginary. If they coincide with any person or person's life, it is purely coincidental. And again, the discussion generated during the presentations are guidelines only. They are not the law by themselves. If you want any legal opinion, please do contact advocates. Okay. So with this disclaimer, I would like to start my presentation on capacity assessment. See, this capacity assessment comes under the Mental Health Care Act in Section 81. Under Section 81, the subsection 1 talks about the Central Mental Health Authority has to form an expert committee, and that expert committee will form a guidance document. On that basis, this capacity assessment will be done. And I was an expert committee was formed actually under the Mental Health Care Act by the Ministry of Health and Family Welfare under the chairmanship of Professor B.N. Gangadhar, the director of NIMHATS Bangalore. Other people were also involved, and I was helping the committee, and I also played a small role in formation of this guideline along with Dr. Nitin Gupta, Dr. Jagdisha, and also Dr. Naveen also played a role in formation of these guidelines. Moving to this, suppose if you have been given the task of making this capacity guidelines, that is mental capacity assessment guidelines. How should it be? How much time it should consume for your assessment? Should it take 30 minutes? Should it take 1 hour? No, sir, it should be comprehensive. It should be 2 hours. Or it should be structured. Structured means 1, 2, 3, 4, 5 questions are given. Yes or no? Or is it somewhat semi-structured? There is an independence given to the clinician so that instead of going for structured, we will have a semi-structured. No, there should not be anything. It should be clinical based what we are doing now. That should be there. And should it be a legal rule? Because the law says that it is a guidance document, not a rule. So it is not placed under any rule, or it is not placed under any regulations under Mental Health Care Act. It's a guidance document. Should it be a clinical guideline or a legal guideline? How much should we codify this capacity assessment as per the Act? So these were the questions, and we had discussion. When this guidance document was done, initially it was very comprehensive. Comprehensive to that level, it required 1.5 hours, 2 hours. And then finally we discussed, did the literature review. Finally, we did some kind of pilot working. And also finally, we had a discussion when the committee met. We were very clear. The guidance document should be to that level like IDEAS. You know about IDEAS, Indian Disability Evaluation Assessment Scale, which is short, which is sweet, considering the population which we are supposed to care as a clinician. And the document should be, the guidance document should be to that level, which can be used easily in your OPD or inpatient. It should not take 1 hour, 2 hours. If we have 1 hour, 2 hours, the whole purpose will be defeated because you will be seeing less patients and the many patients will be waiting for the care. And the Mental Health Care Act starts with the right to persons with mental health where we are supposed to provide care. So we have to balance between the available time and the patient's availability. So on that basis, we ended up forming a guideline which will be very easy to use, not much time consuming, and it should be having around 4 or 5 domains which should be covered. On that basis, it started. Coming to the approach, what is capacity? The capacity is ability to do particular thing. That's what if you look at the dictionary, it talks about that. And also the mental capacity is the ability to make a particular decision at the time it needs to be made or in the relevant time. Please understand, I may have a capacity when I was at the age of 30 or 40. As I grow old at the age of 70, do I retain that capacity? That means I had capacity earlier, but not now. So it's a relevant time is very, very essential. how did this capacity arise? The capacity arises from our Constitution of India, where it says, Article 21 of our Constitution says, right to life and liberty. What is this liberty? Liberty is I am able to legal right to make my own decision. What we call it as a right to self-determination. So I can decide what I want. How much this right should be given to a person with mental illness, at what level we should stop it, saying no, it can't be given to you at level, or else since the Constitution is giving to him, we have to have a mechanism when we are going to curtail, under what circumstances we are going to curtail, to what level and to what time. Is that what the law has to come up, and that has been discussed in the Mental Health Care Act. So when are we supposed to do capacity assessment as per the Mental Health Care Act? Like there are various, like it may be admission, it may be treatment, it may be discharge, valid will, buying a house, to have a breakfast, to participate in rehabilitation services. See, these are the various capacity. That means capacity is not all or none phenomena. Capacity is dynamic in nature. I'm repeating it. Capacity is dynamic in nature. It is task specific. Like a person who is severely mentally ill, who do not have capacity for admission, but he has capacity to decide what breakfast he wants, what dress he wants. That means it is task specific. It is dynamic in nature. A person may have capacity in the morning, but he may not have in the evening. That means in delirium, he may lose capacity in the evening, but in the morning, he is completely fine. So it is time relevant. Coming to the task specific, a person, if I ask you, you may be a MD student or you may be a practitioner. If I ask you which car you want to buy, you may start thinking. You may take 2 days for making this decision. You want to look into your bank account. You would like to discuss with your friend. You would like to do the internet survey, search, talk to a couple of your friends, want to visit a couple of what we call it a showroom, and then you take a decision. That means you being a doctor, you require support from internet, support from various resources. Then you make a decision. That means time relevance again. You may not have today the capacity to decide what car you want to buy, but after 1 or 2 days, by acquiring all knowledge, acquiring your resources, you take a decision. That means you have been supported and you have taken a decision. So capacity is time relevant. It is highly dynamic in nature, and also task specific. A person may not have a capacity for A, but he has a capacity for task B. Like again, right to self-determination. This is a very important component. Like right to life, everybody has a right to determine what do they want, whom to marry, and when to marry. Like suppose if I give an example, a person, you are unmarried. This is again for your understanding. I want to consider this because it's a what we call it as a life event where you can understand. One is rights-based decision. Means I will decide whom I'm going to marry. I'm not going to discuss with anybody. It is my decision. I will decide whom I'm going to marry. That is rights-based decision. Next, which is prevalent in our culture, is proxy decision. The girl or the boy may not have anything to say. The father and mother, the elders of the family will decide. That is proxy decision making, or what we call it as guardianship. So we have two ends of the spectrum. One end of the spectrum is right-based decision. The second end of the spectrum is proxy decision making. But these are the two poles apart. But however, in Mental Health Care Act, somewhere we have started discussion called as supported admission, supported decision making. So what we call it as shared decision making, that is love cum arranged marriage. That is the policy that has been adopted in Mental Health Care Act, where a person likes somebody, he discusses with the family, and the family also discusses, and they come to something called as a consensus called as shared decision making. So now we are having a patient with us. We are not going to take a decision that he will take this drug A. No. Or the patient will decide drug B. It is a shared decision making, or what we call it as supported decision making. So please understand, these are the two concepts: rights-based decision making, proxy decision making, and one is shared decision making. Coming to the other one of the component which everybody should know from legal point of view is, one is capacity, task-based, time specific, time relevant, what we are taking. There is something called as competency, what we call it as legal competency. The legal competency is a term which is used by a legal people, by the court, which will declare a person who is competent or not. If a person, if tomorrow court decide Mr. A is not competent, legally competent, that means he will lose personhood. That means he is not considered valid for having a vote. He will not be able to enter into any valid legally valid contract under the Constitution of India. Whatever he does will be considered invalid. That we call it as unsoundness of mind, basically. So competence is a legal term. There is nothing called as here dynamic. It is the court decides, telling that this fellow is incompetent or legally incompetent person, until the law again says he has become competent. Till then, he will be considered as unsoundness of mind, and it will be considered as incompetent. So, but the mental capacity is dynamic, task specific, relevant time. It is spectrum in nature, and also requires assisting in various degree. And it's most of the time across the world, it's a clinical decision. If you look at the various instruments, I'll be discussing that. The majority of them are clinical decisions rather than the instrument-based yes or no. It's a categorical. And this capacity assessment sometimes may be permanent or a temporary loss. Like, for example, a patient with dementia, like Alzheimer's dementia, once he loses capacity, he may not come back when he develops a severe dementia. So that time we can call it as permanent. Temporary is a alcohol-related delirium. Those are the cases the person comes back and he goes back into delirium. So moving to the what does mental capacity does not equate. Again, this is one of the other very important issue which we need to know. It does not equate with psychiatric diagnosis, either present or past. That means a person had a schizophrenia doesn't mean that today he is incompetent or he doesn't have capacity. That means you have to assess capacity irrespective of his present or past diagnosis. The next important one of the criteria which many of our students mistake is insight. That means the person has insight. That means he has capacity. He doesn't have insight. He doesn't have capacity is wrong. Insight is completely different from capacity. Insight is one of the component of capacity, but not it becomes a complete capacity. So cognitive impairment, that is one of the other component, but it doesn't become capacity. That means a person has a mild cognitive deficit, early part of dementia, still they are able to make capacity decisions. For example, what dress I wear, what should I take, where should I go, where should I live? These are the things they can decide. Substance use. The person may not have complete insight at all about his alcohol use, but he has capacity. He does all his work in his office and he's able to earn money. So then we say, though he doesn't have insight, but he has capacity. Poverty. That means a person is economically down. He doesn't have mental capacity. Wrong. By his looks, it cannot conclude that he doesn't have capacity. Educational qualification. That means these are the correlates which do play a role in capacity, but they do not equate to capacity completely. Coming to the variables, what are the contributing to the capacity? There are many variables which are playing important role in the decision of mental capacity. First and the foremost is medical conditions. For example, medical conditions may be various. It may be metabolic encephalopathy or encephalitis, meningitis. Persons lose capacity at that time. And if you go to emergency, you may find many people who may not be able to take decision. Then the emergency situation, the practitioner or the doctor will take a decision for him. Inadequate information and knowledge. You may not know anything about tomorrow, about a cancer disease, and you have to take a decision immediately. You may not be able to take a decision unless you have been given information, unless you have been told what are the side effects of various available treatment. Then once you get the information and the risk, you will be able to take a decision. That is availability of knowledge and information. Cognition. That means if you are able to have a reasonable degree of cognition, you'll be able to take decision. Organic brain disorders. Head injury, again, can be considered as a component in capacity. Substance use, drugs intoxication, they also play important role in capacity. Symptoms. For example, a person wants to take a decision regarding some property, but he has a delusion of persecution or reference to that person. Then he may not take a right decision. For example, capacity to execute a will. If a Mr. A has to execute a will and he has a delusion of infidelity or persecution towards his wife and children, he may not give the property properly and he may not execute the valid will. The symptom, though he may have capacity in other area, but capacity to execute will not be there. The next comes a psychiatric diagnosis. That means, is there any specific diagnosis which determines capacity? Sorry to say this, no. Many studies have formed, like many studies have been seen, there has some amount of understanding, like bipolar affective disorder and schizophrenia do go in hand with capacity. That means a person with severe schizophrenia or severe bipolar affective disorder, especially mania, do usually loss of capacity is that. These are the two diagnoses which have been found repeatedly in various studies. That doesn't mean all schizophrenia do not have capacity. It's basically the correlate has been found. Violence is one of the other. Violence and involuntary admission has been considered as the people as do not have. Insight, absence or presence of insight. Some of the studies have said absence of insight leads to loss of capacity. Affect, that is mania. The next comes is very essentially socio-cultural belief, that religious belief. Some patients may have their own religious belief. I would not like to take treatment. And that doesn't mean that they do not have capacity. Or they say, I would like to take Ayush treatment. Or else I would like to take some yoga treatment. By the reason of being you an allopathy doctor, and the patient chooses some other treatment modality, doesn't mean that they have lost capacity. That means they have taken a decision which may not yield good results, but they have right to decide what they want. Please understand, they have a right to decide what treatment they want. So paternalistic attitude telling that this treatment will work is not accepted under the Mental Health Care Act. Coming to the another important, again, point of insight I would like to touch upon. See, insight and capacity, they are not synonyms. Insight do play a role, only a small part of the role in deciding capacity. It doesn't mean insight means capacity, because insight has three important components. Please understand, insight has three components. Awareness of illness, one component. The second one is risk involved, because he's not understands he doesn't have illness, but the risk involved that I am ill, I should take treatment. That is lost because loss of awareness. Third one is adherence of treatment. These three components do play a role in the assessment of capacity. So insight itself is not capacity, but insight does contribute in the capacity assessment. Coming to the various tool, like you can, one of the best tool which is available, which is semi-structured, which gives a clinical, openness. Around 1.5 hours you require is Macarthur Competency assessment tool for clinical research. It may be admission, it may be treatment. There are various available. It is there. It is one of the Macarthur scales are one of the best. Next is brief informed consent. You take any other what we have mentioned. These are all what we call it as scales which are specific for certain purpose. For example, research purpose, for admission purpose, for making a valid will. So you have to have a different tools for each purpose. And again, it may be semi-structured, structured. And if you ask me, after working in NIMANS and being a legal expert, I would rather we should have something called a semi-structured instrument where it does not dictate a clinician what to do. It should give an independence to the clinician to some extent. What is the clinical picture of a patient, how much violence he had in the past 1 month, and how much is the diagnosis, how much is the family is able to contribute, what is the cultural context, and what are the symptoms it is happening, how the symptoms are manifesting. On that basis, the clinician should have decision to make, especially with regard to capacity. That is what is done in Macarthur scale, and Macarthur continues to be the gold standard now also. Coming to the main point of Mental Health Care Act 2017. If you look into the section 4 of the Mental Health Care Act, it talks about capacity to make mental health care and treatment decision. There are three important points. It clearly says that the person should have comprehension, that is 4A. B is appreciation of risk, of accepting treatment, not accepting treatment. It may be admission or treatment, and communicating the decision. So these are the three important points which the section 4 talks about. And also it says, before the section 4 started, it says every person, including person with mental illness, shall be deemed to have capacity. That means the law takes a stand where it says everyone has capacity. For example, the way we decide, everyone is sane unless proven that he is insane. Similarly, every person has capacity unless somebody proves that he doesn't have capacity. That is in a particular task. And one more important, again, I'll repeat you, the person deciding that he decides particular admission or treatment which is pursued by the treatment provider or health service provider is inappropriate, wrong, doesn't mean that he doesn't have capacity. So if a person with alcohol dependence syndrome comes and says, with my willpower, I would like to stop, I don't want any treatment, and this capacity is well preserved, you can't say that, no, he doesn't have capacity, it is wrong. He has taken a decision, the self-determination that he will try to do it with his willpower. You cannot say that this is inappropriate or wrong. So you have to give respect for their self-determination. That's how the Constitution of India says. So we being psychiatrists, many of us are very, very, what we call it as, passionate about, no, we have to give treatment. We have to keep it aside. We have to give the respect to the Constitution of India, which gives right to life and liberty. From that, it extends to the person has a right to make decision, and he has right to choose what is right for him. Coming to the guidance document, which I said, section 81, which tells there should be a committee formed to draft this guidance document. The committee was formed and the guidance document is available. We have already shared in the WhatsApp group. Again, it will be shared in the various form. And who will assess this capacity? That is 81(2) subsection talks about this. Every medical practitioner and mental health professional will do this. Every medical practitioner, who is every medical practitioner and who is this mental health professional? As per Mental Health Care Act, medical practitioner includes MBBS, Ayush, including homeopathy. And who are the mental health professional? Psychiatrist, psychiatric social work, clinical psychologist, mental health nurse, and also various professional postgraduates from Ayurveda, homeopathy. They have been considered as mental health professionals. So all these people are considered to be what we call it as are entitled to do the assessment. However, they need to undergo certain training. And once they are trained, they will be able to certify this person has capacity or not. Moving to the principles under the Mental Health Care Act, there are a couple of important principles. First principles I have already told you. Every person, including person with mental illness, are considered to be having capacity unless somebody proves it. That is first principle. We are considering that everyone has capacity. And if the person doesn't have capacity, nominated representative will take over and he will do a supported decision making, not a what we call it as a surrogate decision. Supported decision. That means he will help the patient and discussion with the patient will occur and then the joint shared decision will be made. And the act also says the patient has a right to make unwise decision. Just because it is wrong, inappropriate decision doesn't mean that the person has lost the capacity. And again, mental illness does not equate to loss of capacity. A person may have social phobia, may have obsessive compulsive disorder, may have substance use, does not mean they have lost capacity. And whenever the person has lost the capacity, I'll repeat, whenever a person has lost the capacity, you have to provide mental health care in a least restrictive environment, and it is in the best interest of the person with mental illness. So that means you have to choose where a least restrictive environment is given to the person with mental illness, and also you are providing in the best interest principle. These are the very important principle under the Mental Health Care Act. Various sections it has been articulated, and we have to take this principles in your mind before we do the assessment. Now, when should we do the assessment? That means triggers for assessment. The triggers for assessments are whenever the person, again, the assessment will be done for the person with above 18. Less than 18, the act says the NR, the family members will be the decision maker. That is less than 18, he is a child, so the NRs will take a decision for the child. So any person above 18, the capacity assessment should be done whenever they are planning for registration of advanced directive, whenever we are invoking advanced directive which is registered, during independent admission, during supported admission under section 89, every week when a person is admitted under section 89, supported admission under section 90, every 15 days once when section 90 is being done, before giving any information under section 22. Like what we talk about is shared decision making. When a person is completely has capacity, you're not going to discuss with anybody, you will discuss with the patient. And if the patient has capacity, you will discuss with him and his consent will be taken for treatment. You have to take consent to discuss with his family member. And also whenever we are going to take a treatment related to decision, when there is a intervention is required, like electroconvulsive therapy, you have to do capacity assessment and then you are going to take a decision for giving any major intervention. What are the documentation required? Because the whole assessment process is a guidance document under the law which requires documentation. What are the documentation? Whenever you do a capacity assessment, there is a guidance document available. There is a what we call it as a semi-structured pro forma has been given by the ministry, and that you have to use. And the form, these are the documentation. One is the assessment pro forma. Who did the assessment? When the assessment was started, when it ended, Where did the assessment take place? What decision was made? Why the decision was made? How the decision was made? Who was involved in the decision making? What information was used and what information was given? These are the minimum information has to be documented in your file. That is basically case record. And assessment pro forma, that is which has been ratified by Central Mental Health Authority, that is by the Section 81, under that it has been done. So this is the guidance document which has been made available and it has been ratified. This is the demographic details which talks about name of the patient, age, basically gender, sex, that is basically patient ID, date of assessment, time of assessment, place of assessment, the person who has done the assessment, purpose for assessment, is it admission, treatment, is it for NR, advance directive, any other measures you are doing it. If admitted, under what section the person is getting admitted, if he is already admitted, under what section he has been admitted, whether the person has advance directive. This is very essential, because if a person has advance directive, once the patient has lost the capacity, advance directive will start working, and you will go to the advance directive, and as per the advance directive, you will give the treatment. If there is NR, with the name, ID, and if you have arrived at the diagnosis, you are going to make provisional diagnosis or the confirmatory diagnosis. This is 0 point now. We are talking about the document, that is the assessment pro forma. First is 0 point. What is 0 point? Obvious lack of capacity. That means when a person comes to you and his condition is so severe, especially we see in short stay ward or in emergency ward, we see a person is very violent, excited, or it is catatonic, delirious, and you are not being able to hold a meaningful conversation with him. Such kind of thing, when you will not be able to proceed with your what we call it as capacity assessment, here at this point only you will say the person has lost the capacity, you will jump to the section 4. So this is, and when you do this, you have to give explanation for each point. If you say yes, if you say no, why you are taking this decision has to be documented. That means each point has to be explanatory. It is not just ticking, you have to provide explanation. If you say obvious lack of capacity is there, you have to say the person is having alcohol dependence syndrome. Currently 3 days he has stopped alcohol and is currently not oriented to time, place and person, is not able to talk to him, is not oriented, hence obvious lack. Or else a person is severely violent, you are not being able to go near him, and you have to, before you engage him to talk, he becomes very violent. Then you have to document that the violence, and he has assaulted, how many people he has assaulted, when was the last assault, you have to document this, and then say he doesn't have obvious lack of capacity. That is what is 0. Next, the point number 1. The point number 1 is more of understanding the information, that is comprehension. So the comprehension, basically to know whether the person whom we are assessing, is he oriented to time, place, person. If it is yes, you document that. If it is no, you have to give explanation. What questions you asked, what questions he answered. If you are unable to assess, you have to mention why you are not assessing. Then the point B. Has he been provided with relevant information about mental health care and treatment pertaining to the illness? That means now, since capacity assessment also needs giving information. If I'm admitting some person, I have to give information. We have done the assessment and we find that you are suffering from X, or provisionally, or we are suspecting this illness in you, and these are the available treatment, these are the side effects of treatment, what are the benefit of this treatment, you will discuss with him, and that information is given or not. If you have given, what is the information given, you have to write there, document. If you are unable to give, please you say, I was unable to provide the information regarding treatment, mental health care pertaining to the illness. You have to document. You cannot just tick and leave it. And if he is able to follow simple commands when you are doing physical examination, if you are able to do that, you have to document, yes, he is able to do. The last D point is, does he or she acknowledges that he has mental illness? Yes, no, or cannot. See, again, I'm repeating, this is D is a question which is indirectly assessing the insight. Insight is a part of capacity. Insight is not whole capacity. It is one of the room in a building. It is not the complete building. That means you have a 10-storied building is a capacity. One of the room is capacity. Sorry, insight. So insight is only one room. The whole building is capacity. So that is how I would like to give analogy. The second point, we are going for the appreciation. What is appreciation? It is appreciating the reasonable foreseeable consequences of a decision, lack of decision on treatment or admission or personal assistance. That basically the patient should know, if I take treatment, what are the benefit and risk. If he refuses treatment, what are the benefit and risk. That is what we are going to see. Does the individual, A, point number A, under 2A, does the individual agree to receive treatment suggested by the treating team? Yes, no, cannot assess, you have to give explanation. Does he or she explains why he has agreed to receive treatment? What is the explanation? So if he is in 2B, he will go to 2B. If it is 2C, depending upon what is response. If it is S, he will go to 2B. If it is no, if it will go to 2C. Does he, basically we have created a, to make it time less time consuming, you are giving the skip questions. So depending upon that, you will move forward. The last one is communication. Communicating the decision under the subclause by the means of any means. It may be speech, expression, gesture, or any way he is able to communicate whether he is accepting the treatment or not. That has to be documented here. If he gives in writing, fine. If he speaks, that can be done. So on that basis, you are going to consider. The last part, fourth, that is the decision. What is the decision? The consultant or the person who has taken. Based on the above interview, that is, it may be interview, may be history, it may be complete workup, relevant history, behavioral observation, clinical finding, mental status examination, available medical records. On that basis, you are going to decide yes, because the law gives only two important points. Has the capacity for treatment decision including admission is present or not, or no, he requires high need of support. So that is basically, you have only two options. One, yes, his capacity is there. No, he requires, needs high support. That basically he does not have capacity. He will strike either A or B. Depending upon, if you are choosing 4A, that means he has capacity. Then the signature of the mental health professional along with the client. That means the client has capacity, he will sign along with you. No, 4B, the person doesn't have capacity. Here again, the person, the medical officer or the mental health professional will sign. Now the NR will sign, not the patient. So that means he doesn't have capacity, you will choose the 4B. Depending upon that basis, you are going to do. Along with this, these are some of the anchoring question which is not provided in guidance document. It is basically, we have devised this question so that you know what are, basically these are the anchor questions which can be used. Since this document is basically a guidance document, not a document which will be used, which will be a structured document. So you are free to ask many questions as possible. Some of the questions for comprehension, when you start comprehension, you have to introduce yourself, reason for current interview, please tell me about yourself, ask him about his demographic details, what do you believe is wrong in your health, what the treatment was suggested by or recommended by your doctor, earlier doctor, what did he say, what was the illness you had in the past, does it has been recurred or not, are you satisfied what information has been given by us or by the previous doctor. Those are the question, and to check whether he has comprehension or not. Appreciation. Do you believe that you need some kind of treatment? What kind of treatment you want? Do you think this treatment might be of potential benefit? What are the benefit you are going to get? What are the risks you may develop? What do you believe if you are treated? What will happen if you are not treated? Do you believe there is an alternative treatment options available? How do you accept? How did you decide to accept or reject the recommended treatment? Basically, you are assessing the rationality of the person. So logical reasoning you are trying to choose. That is how the appreciation. And the communication, can you tell me what treatment decision you have made, why you have decided like this? This can be the question. So this is what the capacity assessment is. And I would like to repeat, capacity assessment is very essential. It is, one is part of the Mental Health Care Act, and the capacity is nothing but a liberty, right to life and liberty. It is part of the Constitution of India under Article 21. So the whole Mental Health Care Act revolves around the assessment of capacity, and you should use this capacity assessment guidance document whenever you are admitting, whenever you are every week under Section 89, every 15 days once under Section 90, whenever a person is doing AD or invoking the AD, that is Advanced Directive, that time you are going to use this Advanced Directive, and hope everybody will be using this Advanced Directive and this guidance document for capacity assessment, and it should become a routine practice, and it should be available in all file. Tomorrow, whenever a mental health review board or any other person says on what basis you are decided for admission, along with the criteria for the person is violent to self, dangerous to self and others, the capacity document play a major role in deciding the treatment. Thank you very much.
Thank you, sir, for your lucid presentation. This is a very important session that we have had today, because as I was saying, capacity assessment is mandatory now across the situations when we would want to see a person with mental illness. Now the floor is open for discussion. Dr. Gautam has a question.
Yeah, Suresh.
Yeah.
You said that capacity is data specific.
Not data, no, task specific. Task specific, not data specific.
I think at some point of time you also said it depends on the data that is available to the patient.
Yeah, okay. Data is more basically the knowledge available.
Okay. Now, what is the relationship between the data or knowledge and insight?
Okay, very good, sir. See, the important question, sir, as said, suppose if I have an illness which I am not aware at all, that means I don't have the knowledge about illness. Tomorrow I have been diagnosed with disease X, which I don't know anything. What treatment is available? What is the prognosis? What other alternative treatment is available? Now, if you ask me, what is your treatment decision? Now, I don't know what is it. So somebody has to give me that information. Then once the information is available, then I'll be able to make a decision. That is what is about is information availability is very essential. Even I may be a doctor. Tomorrow I've been diagnosed with X diagnosis. The availability of information, what available that information, on that basis I'll be able to take a decision. So the availability of information plays a role. And before we do a capacity assessment, that is the reason in section 1A of the guidance document, 1B of the guidance document, we do ask about whether the information is given or not. If it is not given, why it has not been given. Because the whole process of assessment depends upon providing information.
There is one proviso here.
Yes, sir, please go
ahead. Does it mean that if you have given all the information,
yes,
and the patient is still not able to understand that he has an illness, insight is present?
Yeah, obviously if he has, see, one of the thing is comprehension regarding the, see again, now what capacity we are assessing? Is it the capacity for admission or is it capacity for treatment decision? These are the two important decisions we should make. Is it for admission? Then we will say, yes, by admitting, what are the benefit is going to get, why we are admitting, what is the diagnosis, why we are admitting, what are the benefit of admission, what are the risk of admission. If he's able to tell that, fine, he has capacity. Now coming to the treatment part, yes, you have a diagnosis, whether you are taking a treatment or not, if what are the other possible treatment you will take. On that basis, if he says no, like for example, alcohol dependence syndrome, the best analogy I can give you is substance use. Maybe you're an IV drug abuser. You tell him you are suffering from severe drug dependence or alcohol dependence syndrome. He says, he minimizes it. I know how to control. I will decide when I to take, and I am not dependent on you. It is your wrong diagnosis, he may argue. Though we may consider that he doesn't have capacity or he doesn't have insight, but he still has capacity because overall he is able to say, though his absent insight is there, he may say, instead of telling you, if you give another example, Mr. X is suffering, do you think he has to take treatment? He may say yes. So it's whenever this is one of the gray area of the assessment where many of the literature, especially in the Western, say absent insight with violence towards the public can be considered as absence of capacity. But if the person is absent insight is there and is cool, calm, and is able to do all other activities, the capacity is well preserved, though his insight is absent.
Isn't there a little issue here when it comes to a person who does not have insight but is deemed to have capacity to make the decision not to take treatment,
yes,
and is carrying a gun?
That the issue here is now, if he is violent, yes. If he
no,
has
he's not yet violent. He's not yet
violent. Yeah. Then whether the issue of carrying the gun has to be discussed. What is the relevance of the gun? Why is he carrying? Is there any remarkable reasons for him? Why not? If he is a police constable.
So which means that you have a person who is a paranoid, who thinks people are out to get him. He has still not become violent. He refuses treatment because he has the as you call it, the capacity to make the decision. And then he goes out and shoots somebody.
Okay. So one of the important criteria of about this Mental Health Care Act and the capacity, this is where what we call it as conflict starts coming. See, this is for a moment, we will just forget about Mental Health Care Act. Okay, I'll just discuss how this Mental Health Care Act, how it evolved. For example, there are many people who may be considered as dangerous for the society at this point of time. Tomorrow there is an election. Now there is something called as preventive detention. I will decide, the police will decide, these are the antisocial elements in this area. I will go and detain them. Because tomorrow there is important function is happening or election is happening, they may create a trouble. On that basis, this preventive detention was used against many antisocial elements, and it was considered to be under the Constitution of India, unless the person has done something, you cannot do against him. So that premise lies on the Constitution of India. So that means you cannot have a judgmental value on any person. So unless you have a strong reason to believe that, yes, coming back to the Mental Health Care Act, now I have kept that preventive detention aside. Now coming to this. Similarly, we are now taking something called as preventive detention, because just he has a gun, he has a delusional disorder, doesn't mean that we are going to detain him. If you are detaining him, you have to have a valid reason. You have to show that he doesn't have capacity. That's where the issue comes in. So now you have to have a proper documentation under what basis. Basically, the accountability of the physician has increased many folds. Just because he's carrying a gun, we may not be able to, or he has a paranoid ideas, we are going to arrest him, we are going to detain him for the treatment. No, it is not allowed under the Constitution of India, under the Mental Health Care Act also. So it has to qualify for under the Section 89 that he has to fulfill Section 89. Along with that, you will assess the capacity. That is how it has to be taken. That means you have to do capacity assessment completely separate. No, it is the combination of Section 89 and the capacity assessment will dictate whether we are going to treat him inpatient, or else in the open ward, or else in the least restrictive environment, that is maybe community. That is how we are going to decide based upon the holistic view of the Mental Health Care Act.
Okay. Sorry, I don't want to dwell on this, but there is one more step to this.
Go ahead, sir. Please add.
Now, assuming that I am assessing capacity.
Yes, sir.
And during my capacity assessment, the person expresses a desire to kill somebody.
Okay.
With his gun. He's carrying a gun, and when I ask him, he expresses a desire, and therefore we admit him. And then tomorrow, you have said that there is a list of mental health professionals who can assess capacity. Let's say tomorrow, somebody else examines this person where it comes to the question of his capacity. And that person at that point of time, he says, no, I didn't tell the doctor that I will kill.
Okay.
What happens then? When at that point of time, based on that person's assessment, he decides that the person had a capacity and you have willfully admitted the patient against his wish.
The assessor deals that considering Section 89, okay, and he is dangerous to self or others, and he says that capacity is absent. Now he will, with available information, again, if you look at the Section 89, it says with available information. It may be information collected from parallel sources. If you are able to prove that under Section 89, it was dangerous to others, and the capacity assessment says that yes, under that he doesn't have comprehension or the appreciation of risk is missing. That's what the problem with the insight. Insight has three domains. Again, I'm repeating. Insight has three domains. First and foremost is awareness of illness, acceptance. Because he is ill, that means he has to weigh. If I'm ill, I have to weigh whether if I take this treatment, what happens? What are the benefit of treatment? What are the risks of treatment or alternative available of treatment? And the adherence to treatment. These are the three components which the insight is being evaluated across the world. And now these three also part of the capacity actually. But the issue now deals is if I am not ill, somebody else is ill, the capacity is well preserved. I'll say that person is suffering from diabetes mellitus. He should take treatment because these are the complications if he doesn't take treatment. But when it comes to me, when I have to decide for myself, there the involvement of self comes into a picture where the capacity, though we say that for him it may be absent, but still the capacity is there. So you have to take a holistic picture of Section 89 along with capacity document, then only we will be able to take a decision for individual cases. And again, if you look at the regulations, it is very clear. The decision, what today he has capacity, he may not have tomorrow morning. A person may say, I'm carrying a gun, it is for my protection. Tomorrow, when you do today I have done the capacity assessment, he is fine. Tomorrow evening, he has taken alcohol under the intoxication, he may shoot somebody. That doesn't mean that my capacity assessment is wrong. When I did the capacity assessment, he had capacity, but when he had taken alcohol or his symptoms may exacerbate tomorrow morning, where he may become violent. So depending upon the situation, that is the reason capacity assessment is not static, it is dynamic in nature, it is relevant to time. Today he has done, but however, that is the reason even the capacity assessment, the reasonable degree of time is given in section 89 is every week we have to assess. Under section 90, it is every 2 weeks once, has to be assessed. That is what they say. It is reasonably for 89 is 1 week, for 90 is 2 weeks, because it's a long duration of admission, more than 30 days. Thank you, sir, for bringing a very important discussion under the insight and capacity, because it is, if you look at a couple of articles which has been published in BJP during 2007 and 2008, they have discussed about insight and the capacity, how do they interact each other, and how do they play a role, and BPAD, mania and schizophrenia do go hand in hand with loss of capacity and insight. So though many patients said that I don't have illness, but still I would like to take treatment, though that's what we call it as double bookkeeping. I am not schizophrenia, but my doctor is telling, my family is telling I would like to take treatment, then the capacity considered to be present under that when they are done the, what is that, assessment using Macarthur scale. So depending upon what type of questions we are asking, that also determines the capacity also to some extent.
Right, sir. I have only one question. Is this similar law is applied to every time if every any prisoner come to our hospital or any other mental health facilities? If,
Yeah.
A prisoner came to a mental health facility for admission or simple psych evaluation, does we have to do capacity assessment on him before doing that?
Yeah, if you see, for the admission purpose, we have a section 103 for prisoners. So depending upon the state prison manual, see, for example, not only prison, it may be from the army, it may be from the navy, it may be from the border security force, various, they have a separate laws. Depending upon their manual, you have to take a decision on that basis whether we are going to admit or not, because they will be coming under section 103, not under section 89 or 90. So on that basis, depending upon, like certain state may say, the medical superintendent will be the guardian for a convicted prisoner. He will take a decision for him. So the liberty has been already curtailed under the law, under that specific state where the prison superintendent make a decision as per the jail manual. So every state has a different jail manual. They decide on that basis who will take a decision, a proxy decision. They become the NR most probably, depending upon that. So on that basis.
I have a question, like in the guidance assessment document, there are lots of yes and there are lots of no's. Do we have to mark all as yes?
Sorry, there is a skip questions are there. For example, can you tell me section 0 is, if it says that he doesn't have capacity because obvious, by looking at him or by interacting with him for 2-3 minutes, you will come to know he has obvious lack of capacity, you would immediately jump into 4.
For all the applicable questions, like in the scenario, if the question is applicable, we are not going to skip it, we are attempting that question.
Yes.
Then if any question is marked no, then can we say that the person does not have capacity?
No. See, the skip questions will be available only for 0. From 0, you will be immediately allowed to jump to 4. But when you go to 1, there is no skip question. When you go to 2A, you will be allowed to either jump into 2B or 2C. 3 is compulsory. That is the way it goes.
I'm saying for all the applicable questions, like for whatever the questions we need to ask him, what we are asking him, not skipping or skipping. Does any no, like if any question answer is no, can we finally say the person does not have capacity because of this particular point?
No, it's not like that. It's the whole finesse. These are the guidance document where we, for the comprehension, we have around 4 questions. For appreciation risk, we have around, requirement is minimum, I think 3 questions we have given there. So depending upon whether he has there or not on that basis, because though the Mental Health Care Act section 4 talks about or, actually one of them, if that means it, as per the current Mental Health Care Act, the way it is been drafted or it has been gazetted, if it is one is present, That means he has capacity. It is or. But actually the guidance document says and. That means one is missing, the capacity is missing. That is the way it has been taken.
Like if in understanding there
Yes.
are 5 questions.
Yes.
There are 5 questions in understanding. For one of these questions, the answer is no. Like the person is not able to understand one of those 5 things. Then I can say that the person does not have capacity because this part of
no, you have to go for the second question. 1A, 1B, 1C, 1D. You have to go.
We go for all 5, but we don't need all 5 for yes to say that he has capacity.
No, not required.
Not required.
Yes.
If in point number 5 he does not have insight, so the answer is no. It is not.
No. You have to holistically take comprehension as complete. Not this based on one question. Not based on one question of 1-4. That is insight.
So if we go for as a whole, then it becomes a spectrum kind of thing.
Yes.
Then
good.
These are 5 points. 1, 2, 3, 4, 5 points, and one of these he will say no. Like insight he does not have, but he can tell me like he does understand that he needs treatment, but he does not understand that he has an illness.
Yes. So that absent insight doesn't mean that he doesn't have capacity. That's what I would like to say. If you look at the 1A, we have 4 questions. If he is not comprehension for time, place, person is not there, and he is unable to answer A, B, C, D, then you will holistically take understanding information is not there. Comprehension is completely absent, and again you will further attempt B, that is second part, appreciation, and then communication. Then you will go, because there is no skip question. Skip question will consider is 2A. From there you will jump into 2B, 2C. The skip question comes only in 0. Here, obvious lack of capacity. 1, 2, 3 will be attempted. There will be no skipping here.
Sir, what is the stand? Excuse me, sir. What is the stand of the guidance document on the thing that a person reluctantly agrees to take treatment?
Okay.
But in the capacity assessment, like he does not have understanding completely holistically. He does not have appreciation holistically. But he is able to communicate. The 2 things he is lacking, and he's still agreeing for treatment. So we don't care much about that.
See, what is the repercussion of this? You have made a statement, he doesn't. No, see, at the end of the day, what the issue here is, the person has to be considered as liberty has been curtailed. The liberty has been curtailed based upon comprehension, appreciation of risk, and the last one is communication. He says, I will take treatment, I will not take treatment. He passively nods his head. But A, B is not been there. But for example, he is unable to understand the comprehension, he is unable to do, then you have to say capacity is absent.
And still go ahead with the treatment.
Go ahead with the treatment, but you will be using NR's signature, and you will discuss with NR along with the patient. It will be a shared decision making. It is not in the absence of patient. With the patient and with the NR, you will be sitting with them, discussing about the available treatment, and then you will finally take the decision of the NR or the signature of the NR telling that you will enter into 4B, where you will say it is that means the consent has been given by the for the legal purpose by the NR.
Sir, one more thing I have to ask.
Go ahead.
In the understanding section only regarding point number 4, sir, if a person does not appreciate that, like he does not understand that he has illness, insight is absent, and by the virtue of that thing, he's saying, I don't want to take treatment. Since I don't have illness, why do I need a treatment? So, sir, shouldn't this be considered incapacities in its own? Because out of those 4 things, he has all these 3. He is oriented, he is understanding the information he's given, you can recall it, but he does not have insight. And by the virtue of insight, he is denying treatment. And this person does not have capacity.
Yeah, I completely go with you, especially in case of delusional disorder. That is the way. He says, I don't have delusional disorder. Yeah, see, that is where the holistic picture has to be taken, where you will take section 89, and again, section 89, you have to read the section 89 completely, the way he has been brought, who is brought. And then you will take a decision whether, since he is very violent, and then he doesn't have capacity, he doesn't have insight, and the violence is there. There are legal cases where in US there are many cases, and even European Union there are a couple of cases which have been EHR, that is the European Human Rights Commission, in that there are various cases have been there where the person has been considered, the review boards have given decision in favor of doctors going ahead with the treatment because he has been violent, and he has, though he has a capacity telling that he knows what are the side effects of treatment, but he doesn't have insight for his illness. So under that circumstances, they are given permission for go ahead with the treatment, especially in mental health review board. Most of the cases which have been challenged in UK, many people, if they are logged in, they can highlight what happens in UK, where there is something called as Mental Health Care Act. Also, there is Capacity Act. So there are two different acts are available there. There, how the decisions are made slightly different, but again, there the go-ahead will be given by once the sectioning is done. Capacity Act doesn't come in, but however, the treatment can be challenged in the court of law. That I have been detained against my wish and will. The treatment has been given against my wish and will. The review board gives a decision no. Though you may have capacity to some extent, we considered that considering the best interests of the society, we may have to give consideration to go ahead treatment. So it is based on the individual review board. Basically, let's understand that we will be asked questions for going against the capacity of a person or going against the will of a person. We have to have a good document. So whenever we are doing supported decision making under 89 or 90, we have to have a very good document, and we have to document the loss of capacity, and what decision you're taking has to be documented properly. That's what is going to save. And again, in the regulations which is going to be gazetted, it's very clear, just because a doctor has made, or the psychiatrist or the mental health professional has taken a decision that he has been to be admitted, it's a clinical error, cannot be considered as a, what we call it as a negligence. It has to be associated with, like I may take a decision to admit or not to admit Mr. X. That may lead to some problem. That my clinical error cannot be considered as a medical negligence or a criminal negligence, which can be punished. That means negligence should be to some extent associated with the modified intention. That has to be there. Then only the negligence case can come in, because you look into any of these UK or Australia, Canadian based, many a time the doctor has detained, but the review board said, please discharge him. They have not punished the psychiatrist unless the patient is able to prove there was a modified intention doing ABCD against me. That is the reason the treatment provider has taken this route. Then, of course, the law comes into picture to punish. Otherwise, mental health review board is more of a civil case. It will be asking the treatment provider to admit or discharge or revoke the advance directive. It's basically our decisions will be under scrutiny. That's what is about the review board and how the Mental Health Care Act has been drafted.
Thank you, sir.
And please do understand, just because a patient does the capacity assessment is done, you have done the due process, you have done the procedure, and the clinical error, I may say the capacity may be absent, but the mental health review board on contrary may say on that day, after 1 week or 2 days or 3 days, when the capacity assessment is being challenged in the mental health review board, the review board may say, no, he has capacity, you have to discharge. That doesn't mean that your clinical judgment is wrong or your treatment decision is wrong. It's basically, it's an opinion that liberty which you have curtailed has to be given back to the person. That's what it's about, Mental Health Care Act.
Since we are talking of a shared decision,
yes, sir,
with the NR, in the absence of an NR,
okay, sir,
who can be considered an NR? Can it be any relative who accompanies? Can be considered, if I'm not mistaken, according to section 14
of the NR, sir. Right. It has given clearly the family member, relatives, or if nobody is there, the social welfare department representative can be there. And also it has mentioned if a very good available NGOs well formed, they can be doing. So these are the various options has been given. So one is that one. Currently, like one of the question I think raised in one of the WhatsApp group, they said there is no NR. So many a time the available NGO who is working for the persons with mental illness can be considered as an NR, and they can provide. That means they will be acting in the best interest of the patient. They can be chosen for a temporary NR unless the social welfare department comes up with telling that we will provide this person as an NR for this patient. So shortly, unless we start discussing with the social welfare department regarding this issue, and tomorrow this will be an issue which will be taken care as per the law.
Sir, my question is regarding the treatment in OPD basically, because we know in OPD there is a huge rush. We see, and each psychiatrist see around 50 patients on an average when I talk about in a public sector hospital. So how much necessary is to do the assessment, capacity assessment regarding the treatment, because you are advising a treatment. For example, any patient who has come, maybe you are doubting, maybe you are not doubting, but how important one is to assess the capacity for treatment. Secondly, because we know in OPDs, you are just prescribing and not enforcing the treatment. Is it about the implied consent that they have come to you, ask a consultation, or are you providing treatment? So that is my question.
The capacity assessment triggers we have very clearly mentioned. It is more of during admission, during advance directive. Routine treatment prescription of medicine capacity assessment is not required. For example, if you are planning a electroconvulsive therapy on outpatient basis, like even in NIMANS, we do give ECT, electroconvulsive therapy, on outpatient basis, alternative days. On that time, I would definitely like to go ahead with telling that capacity assessment will be done. If the patient has capacity, he will decide, yes, he has agreed for treatment. I will take a signature and I will post him for ECT. Just for medication, I would like to go with medicine, especially oral medication. I would like to take implied consent rather than going for a capacity assessment and the consent. Yes, sir.
Okay, a corollary to that.
Please.
What would be the jurisdiction of the mental health review board?
Okay, it's a mental health review board depends upon the state. Like for example, the only state which I know as per my knowledge goes, the Himachal Pradesh has 5 review boards at this point of time, but there are 14 districts or 12 districts. So the state mental health authority will decide one mental health review board will be in charge of 3 districts. Some state may say we will have 2 mental health review board, though the act is very clear. Minimum 1 MHRB for 3 district has to be there. That's what the central rules, and also the persons with right to mental illness rules also talks about minimum 1 MHRB for 3 districts. That is where the jurisdiction comes. No, sir, we have a very good resources budget. Some state like Kerala may say we will have mental health review board in each district. So that district becomes the jurisdiction, sir.
Yeah, my question is more specific.
Go ahead,
Does the MHRB decide mostly on admissions or on any treatment?
Sir, the mental health review board is in charge of the rights related issues. Anything, and again, if you look at the mental health review board, the roles and responsibilities have been clearly marked in the, it clearly says what are the roles and responsibility. It may be invoking, it may be admission, it may be treatment. Like the patient challenges, my treatment was not to be given like this. As per the advance directive, I have written like this. Or else my treatment choice was A and the doctor has given like this. Depending upon the MHRB would love to, may consider the case for the decision because it may consider it as a rights or advance directive or NR nomination or documents related issues, medical record related. So all these issues, mental health review board definitely will deal with that, sir. If the patient challenges, he has all the right to go to MHRB, and the MHRB can consider, no, the doctor has taken the decision to give treatment which is in your good interest, it may decide, or else it may say, no, we would like to entertain the case. And they may do the review of the case.
Dr. Balaji has asked, do you apply this guidance document for every patient admitted, or only if admission is under section 89 or 90?
I would rather say the guidance document is very clear, even for a person with a voluntary admission, and as 86 you are admitting, for the person who is independent admission as per the Mental Health Care Act, it is not called as voluntary. For independent admission, yes, we are going to administer capacity assessment so that by chance after some days he becomes severely ill and we are shifting him to 89 from 86. Then we say he was under 86, we are shifting to 89, capacity was there, now capacity has lost. On that basis, we are going to consider, and it will be admission for all cases. Apart from children, we will not do capacity assessment for children. Otherwise, we will be, for all admission, will be under 86 or 89 or 90, we will be doing capacity assessment.
Sir, my question is in continuation to my earlier question about the treatment in OPD. As you said that it is important to take capacity or assess the capacity in case when you are giving special treatment, for example, ECT. What about long-acting injections? If you are planning for LAI, because you have to plan for few months to years, a long-term treatment, and person doesn't have the insight.
I would definitely consider capacity assessment in that situation. Vishal, I would definitely go. Even in case of clozapine, yes, I would like to take. Whether if the patient doesn't have capacity, I'll take the family member's consent, I'll go ahead. Even for clozapine, I would like to choose the capacity assessment in such cases. Yes.
Better
Yeah, go ahead.
better if we do capacity assessment in all cases wherever there is significant doubt. And even
Yes, I agree with you, Vishal.
And even in each follow-up, actually, for example, if there is insight right now, or not inside the capacity, maybe the person, because of deterioration in his clinical course of illness, loses the capacity after say 1 or 2 months, and goes to the court and says, okay, this is the problem, I've never said this, and the court will ask, where is the capacity? You said that you have done it 6 months back.
Okay. Vishal, I would like to put it in this way. You can say the law, everybody has capacity. That is, the law says by default, everyone has capacity. The only thing has to be proved whenever we do something against his wish and will. If you are giving any injection against his wish and will, that means we are violating his liberty. Then we have to establish he doesn't have capacity. Otherwise, if he had capacity, we will say that he had capacity. He has to prove he did not have capacity. That will be very difficult for him.
Okay, so every mental health professional, especially the psychiatrist, while prescribing or giving an intervention, at least they should keep in their mind that if there is a doubt, definitely in any of the setting, they should document.
Yes, right? Please, because it will end up in the section 4, the point number 4, either the NR will be giving or the patient himself will be signing the document for the capacity assessment. I think it's a valid point, Dr. Vishal. Considering the way the things are going, tomorrow, I don't know whether the amendment of the guidance document may come after 4 or 5 years down the line. That may be, Vishal, may be one of the, say that whenever you are doing some deviation from normal practice, routine practice of prescribing medicine, you are doing any injection or intervention which requires the consent has to be taken, you may have to do capacity assessment. I completely agree with you, Vishal.
Thank you, sir. Thank you.
Sorry, coming back to the MHRB, I just went through the MHA. Now, the concern here is because many people are looking at the MHRB as a bogey to be scared of, to be running from. But I do not find any reference to treatment in general. Basically, the MHRB has jurisdiction where the advance directive is concerned, or the NR is concerned, or admission is concerned, and not in the general treatment as it's happening today in the OPs that are going on, unless and until, of course, it comes down to the human rights issue. I don't think the MHRB is going to extend its jurisdiction everywhere, because A, it may not have the capacity to do so, and B, I think it would become a huge task by itself trying to monitor every single psychiatrist or mental health facility.
Yeah, it is the powers and functions of the board under section 82. It is clearly, it says, subject to provision of this act. I'm just reading the powers and functions of the Mental Health Review Board under section 82 of the Mental Health Care Act. Subject to the provision of, it is 82, the provision of this act, the power and function of the board shall include all or any of the following matters: to register, review, alter, modify, cancel the advance directive, to appoint a nominated representative, to receive and decide application from a person with mental illness or nominated representative or any other interested person against the decision of the medical officer or mental health professional in charge of mental health establishment or mental health establishment under 87, 89. That means, see, the 82C is very clear. It says, I'm just showing that 82C is very clear: to receive, I'm highlighting this, to receive, decide application for person with mental illness, nominated representative, or any other interested person against the decision of medical officer or mental health professional in charge. The decision may be anything, sir. So the decision may be treatment, it may be records, it may be admission, it may be change of taking somebody else as NR. So that is the way it has been considered. Or else you may take he to adjudicate the complaints regarding deficiency in care and services. I have been given a medication which is considered as deficiency in care because I was supposed to be given the gold standard treatment, but the doctor has decided something else. So there again it may have. So the if you ask me, it has been given some power where they can consider it, sir.
No, again, that section which you just read out in 82,
yes, sir.
That clause which you read out,
yes,
has
sir.
to be read in conjunction with section 87 and 90.
Obviously,
which again is deals with the admissions. There is no reference to the jurisdiction of MHRB in treatment in general. It is specific to admissions or NR or advance directive.
okay, if you look at the 89, sir, the heading of the 89 case says admission and treatment of persons with, so admission and treatment of persons with mental illness with high support needs in mental health care establishment up to 30 days is 89. If you look at the 90, it also says, it doesn't say just admission, it says admission and treatment of persons with mental illness with high support. Sir, it's let me be very clear. It is the liberty which is going to be discussed here, because the judge will be very clear. He doesn't know what is admission, what is treatment as per se. He says, you are doing something against the patient. Have you taken the consent? That is the issue which will be revolving around. So that's how, if I am a judge, I am going to decide the case.
So if you have taken a consent,
yes,
there is no problem.
No, sir, it should not be. Because the Mental Health Care Act goes with the premise, rights should not be violated whenever you are providing services. If the patient has given consent, why not, sir?
So which means that it is safer for every psychiatrist to take a consent from every patient.
I just worded what Vishal said. Tomorrow, yes, it may be for all cases, it may come, sir. Because looking at the way the scenario going on, it would be appropriate to consider consent, especially we are deviating just by prescribing a medicine or prescription. Oral medication may not, but if we are going for any long-acting medication, yes, I would like to consider, especially clozapine. Even if it is a medicine only clozapine, I would like to take a consent. That I have explained the side effects. Medicine has to be stopped if the WBC count falls below this, and family members also signs it. I would like to be as cautious as possible, sir.
In the Mental Health Act 1987, in the end we had a section which says that any decision taken by the psychiatrist which is in good faith of the patient, the psychiatrist cannot be, not held responsible, like it will not be punishable under this act. So do we have any provision for the safety of psychiatrists under this Mental Health Care Act also?
Sorry to say this, such clause is given for the mental health review boards and the state mental health authority, not to the psychiatrist. But however, unless, see again, just a clinical error of judgment cannot be considered as will be lead for a punishment. So there should be a malified intention behind your decision. Then only the punishment will be given. And the MHRB is not going to decide about the quantum of punishment, anything, because it is a civil court. The civil court will make an observation about your clinical error decisions, and it says it's an error, the patient should be discharged, or it is an error, you should stop the treatment. That's only. Unless the patient says, no, there is a malified intention, the malified intention is ABCD, and is able to prove, then the case will be referred to the criminal court for quantum of, for the discussion about whether this, what we call it as the clinical error was beyond reasonable doubt. That has to be established. Then only the punishment has been given. And if you look into various rulings, especially in UK, Australia, Canada, we have found that the psychiatrists and the many mental health professionals have not been punished for their clinical error of judgment. For admitting a patient, no, on that day he was violent, I have taken a decision for admission. The review board said, no, you have to discharge him, he has liberty, he has capacity, you have to discharge. That is the way the court has taken decision. It is not the punishment. So need not be apprehensive that just my clinical error is there, I will be punished. No, the judge would not like to do, or the MHCA chairperson would never do that unless he finds there is a severe gross negligence, or what we call it as malified intention is there. Till then nobody will be punished. That much I can assure you, being a colleague from my side.
And sir, have the people started converting into this Mental Health Care Act? Because many institutes have not started using this capacity documentation as yet.
Yeah, in NIMANS we have started using it, but other institute, see, it's like this. Especially in India, many state may say we have not formed state mental authority, we have not started mental health review board, we don't have XYZ. This is how the state progresses. By chance, tomorrow I'll give an example, okay? This is an example. There is a institute X, says in our state there is no mental health review board, they have not formed state mental health authority, I will not implement Mental Health Care Act. 2017, because these bodies are not there. Patient suffers some injury. He goes to the court. The judge will, the patient will go, I have suffered injury because of this. The first and the foremost, they will call who has admitted, did you follow the state mental authority? The Mental Health Care Act. You say, no, sir, SMHA is not formed, MHRB is not formed. If you go on telling that, they say, did you follow Mental Health Care Act? They will ask, did you follow the consent form? Did you follow the capacity assessment? Then they will say, did you send the information to MHRB? Oh, MHRB is not formed. Call the respective people who have not formed MHRB. Oh, why state mental authority? Call the person who is in charge, CEO, call him. He is the legal representative. Everybody will be taken to task. Just because SMHA is not there, just because MHRB is not there, I will not follow Mental Health Care Act. Sorry. As a judiciary who is the, what we call it as the court, who is the guardian of the Supreme Court and also other laws, they will take it seriously. Every stakeholders will be called upon. That is from Health Secretary or maybe CEO of the state SMHA, MHRB, and also the person, the establishment who is in charge will be held responsible. All three will be held responsible. So we can't say that just there is MHRB is not there, SMHA is not. We have to do our bit to go ahead. Like for example, in Karnataka, in NIMANS, what we have done is, we have started using all the capacity assessment pro forma. We are using all the, what we call it as consent form under 89, 90. IBAS has already started doing it. It will take some time. I agree with that because it cannot be overnight. Even the judiciary also knows that it will be a time to change. The change process, it's a process, not overnight. So it will take time. Please start using those pro formas, start using those admission pro formas and also the capacity assessment. But don't get caught in the wrong side of the law and you may have to say, sorry, sir, I have done mistake, I would like to come out. So you may have to say sorry. And invariably, the court have been very, very, what we call it as helpful to the doctors rather than punishing to the doctors. Obviously, in civil cases, the court have become heavily penalizing under the compensation, but not for the criminal cases. Criminal cases, none of the court wants to give any punishment to the doctor because it gives a wrong precedence. But however, in civil cases, they are giving a huge quantum of punishment. It has been a very wonderful talking to you people. And Dr. Gautam sir, you've added more to our discussion, Vishal, and other people who have added. I hope this class was very helpful to everyone. And thank you very much for spending time. Dr. Chetan.
Thank you, sir. Thank you, all the participants, for the wonderful discussion that we have had. We have taken half an hour extra for this discussion. That shows that everybody is interested and everybody wanted to know, and it was a lively discussion. Thank you, everybody. We like to place on record our thanks to Linux Laboratories Chennai for supporting us through their educational grant.